So this is to show you, this is the DPP. You've heard about the DPP was the study that showed us that diabetes can be prevented. And there were 3 arms. This is where we ended up having nitroglycerol, and it ended up being stopping when we had the problem with that. But what this showed is that lifestyle changes were sustained for 4 years. We're able to reduce the risk of developing diabetes by 58%. And that's pretty significant. So yes, it can be done. What we are translating out of this study is where we got the exercise recommendation of 5 days a week for 30 minutes. So if you can lose 10 to 15 pounds, exercise 5 days a week for 30 minutes, it's going to translate into hopefully these results. And right now, the CDC working with University of Indiana and the YMCAs have started prevention of diabetes programs in targeted YMCAs around the country. So you're going to hear more about that. They're actually doing it with United Healthcare. There was an article in the New York newspaper about 2 weeks ago, I believe. So you're going to hear more. We've been talking a lot about treating diabetes, but when we get to prevention, we haven't had a lot of tools there. We have them now. The programs are being implemented and they're coming. So what the results of our study is that people that go through diabetes education are saving money in healthcare costs and have better outcomes. They're more likely to adhere to recommendations for screening and HEDIS measures. They're younger, so the demographics is we found these were women, they were younger, they came from more affluent areas, they have lower clinical risks, and they adhere to diabetes care recommendations. So what I am, this is the programs that were looked at. We looked at like 4,000 different charts. But if you went to where I work or to many of where you work, what you're going to find is not affluent women. It's indigent, everything. So it probably just depended on where the sample was taken. It's not that only diabetes education only goes to this, but this study, this was just clarifying where a sample came from. So physicians and patients exhibit high variation in use of diabetes education. And we know that, and I'm here to tell you that you should all do it in some way. So people with diabetes treated by high users of diabetes education have lower average cost. We made that clear. The difference are driven by inpatient costs, like we saw by the red bars, and outpatient and pharmacy costs are higher. So the study concluded that diabetes educators collaborating with physician practices result in improved quality and reducing cost for those with diabetes. When the first year this program was done, they only invited the residents. Last year, we invited the faculty and the residents, and we figured that there was an element missing. And this year, we brought the diabetes educator or the person in the team that is in charge of doing the education. So we really are bringing it all together because we realize, and I hope you all do, that that's how all of these changes are going to take place. So I'm just going to talk about different diabetes education models, and I'm going to talk to you about behavior change. There are 3 models that could be implemented. One is where the diabetes educator works independently. Dietitians can be Medicare providers, and they can come and contract with you and come to your office and provide dietitian work. That will be one model. You could hire, we were hearing from this table, that they have a dietitian and a pharmacist in their practice. So you could have within your team already elements of the diabetes education team. Or if you're in a hospital, you may have a diabetes education center, and you can have resources that you could either send your patients there, or these people could come to your practices to provide diabetes education. So there will be the 3 different ways of doing it. This is the framework that we utilize to do our diabetes education. And this is work done by the American Association of Diabetes Educators, and we call them the AADE7. So when you're dealing with your patient with diabetes, you must address all these areas for your patient to really optimize their diabetes control. So this area, and I'm going to touch on each one individually: healthy eating, being active, Monitoring. And monitoring doesn't only include blood glucose. What else do you think monitoring includes? Blood pressure, weight, lipids, depression. So you're really looking at the entire status of health for that patient. Taking medications, problem solving. Problem solving is key to learning from your own experiences. You can tell your patient in your office, this is what's going to happen, but it didn't quite happen that way. But the elements you provided should have allowed that patient to problem solve in the situation that they were presented with. So it's very important that your patients learn how to do this. Coping with their diabetes. Are they still in denial? Are they accepting this? And then reducing risks. What do you think is the most simple element of risk reduction that we make sure our patients are following with? You need to have a physician, because sometimes they come to us without having one of you. You need a doctor, and you need to follow with your doctor. How can a patient with diabetes take care of their diabetes if they're not following up with you? So that would be, to me, the most element of risk reduction pieces. So I'm going to present you with a very simple case study, and then I'm going to share with you all the different behaviors, and then I'm going to ask you some questions. So this is a female, 42 years old. She has type 2 diabetes and was diagnosed a year ago. She has a random blood glucose of 286, an A1C of 11.8. Her BMI is 32. Her blood pressure is 130/90. Cholesterol is high, 269, LDL high, 174, HDL 35, and triglycerides 280. So, you know, very typical. She's on metformin, 500 just once a day. Her social history, she's single, she has 2 young adult children, and she works as a manager of a warehouse. Her behavior assessment, she eats 2 meals a day, exercises 15 minutes twice a week, drinks 2 glasses of wine 3 times a week, forgets to take metformin 2 to 3 times a week, owns a meter but has not tested in over 6 months. Have you heard this before? Every day. So let me go through each behavior, and I'll tell you how we do our work, and then I'm going to ask you what you will do with this person. So what do we do around healthy eating? Let me make one point very clear. I am a nurse. I am not a dietitian. But as a diabetes educator, I have a responsibility to address diabetes healthy eating with my patients, because all my patients don't have the luxury of seeing a dietitian. If patients see a dietitian, but they don't see a nurse or a pharmacist, that dietitian has the responsibility of going over medications, of going over all the things that should be my role. So when we come together as diabetes educators, we're all baseline of making sure that we're covering all those 7 areas. Okay? I know sometimes there's confusion. There's a dietitian and there's a diabetes educator. There's a diabetes educator. You can get started, and if your patient needs a dietitian, you can refer to them later. Or if you have a dietitian, make sure that that dietitian is covering the rest.